Today's topic is viruses and their multi-system impact testing, tracking and therapy with Dr. Armin Schwartzbach. These webinars are recorded and can be viewed at any time by logging into the NANP members area where you can earn 1 continuing education credit. Okay, so let's get started. Dr. Armin Schwartzbach is a medical doctor and specialist of laboratory medicine. He is also the founder of Armin Labs in Augsburg, Germany. Dr. Schwartzbach has been at the forefront of tick-borne research for more than 25 years and is an expert in diagnosing and treating infectious diseases. He is an advisory board member of the Academy of Nutritional Medicine based in London, England, and board member of the German Borrelias Society and member of the German Society of Clinical Chemistry and Laboratory Medicine. He has served as an expert and advisory committees on Lyme disease in Australia, Canada, Ireland, France, England, Sweden, and Germany, and is director of several other organizations. Welcome, Dr. Armin. Thank you for joining us today. It's now over to you.
Thank you very much, Andrea. Maybe I could also announce another honor to me. It's I'm now the board member, director of the ILA-DF in USA, which is the International Lyme and Associated Diseases Society Foundation of the islets. So I'm really happy to serve there scientifically and with organizations. And today I want to talk about viruses and their multi-system impact, about testings, one of my specialties, tracking of the testings and therapy options. The agenda today will be in the first part talking about herpes viruses, enteroviruses, other species. The second part will be about associations of viruses with different health conditions. I will name a lot of syndromes, myalgic encephalomyelitis, ME, or fibromyalgia, or autoimmune pathologies, neurological conditions, cancers. Cancer is also very interesting now to me. I worked as an internal doctor in a hospital with chemotherapies and doing a lot of cancer treatment and years ago. So very interesting to check for infections. You will hear later on. In the third part, I will talk about SARS-CoV-2 and COVID-19 and viral reactivations. Very interesting. Also this testing techniques for sure in the fourth part, checklists and other resources to make it easier for you to diagnose clinically supported by laboratory tests. And in the last part, I will talk about therapy options. So we will focus on 4 different viral groupings today. It's the herpes viruses. These are double-stranded DNA viruses. The second group is the enteroviruses group, single-stranded RNA viruses. We will talk about a little about parvovirus. It's a single-stranded DNA genome, and coronavirus. You all know about that for sure, more than enough. SARS-CoV-2, the enveloped single-stranded RNA virus. So what about the herpes viruses? The herpes viruses are a large family of DNA viruses that cause infections and certain diseases in animals, including humans for sure. Herpes viruses can both be lytic and latent infections. That's very important in expressions. We say lytic, or some say lytic and latent infections. Maybe you say lytic active infections and latent more the sleeping infections or the silent carrier infections. We have nowadays 8 key viruses in this family of the herpes virus group, all of which we can now test for in certified and IVD registered tests in a lot of laboratories in the world. The first is the herpes simplex virus type 1 with a cold sores on lips, also fingers and hands. The second one is the herpes simplex virus type 2, the HSV2 subtype with genital sores. The varicella zoster virus, also called the herpes varicella, the herpes zoster, the shingles, the Epstein Barr virus, which will play a really important part in my presentation, the cytomegalovirus, the human herpes virus 6, HHV6, and the human herpes virus 7, HHV7, and the human herpes virus 8, HHV8, sometimes also called the KSHV. So on the right side, you see how Epstein Barr virus looks like. You have a viral genome, you have an envelope, you have envelope proteins, you have nucleocapsids and viral teguments. So herpes simplex virus 1 and 2. This virus is obligate intracellular, and as I mentioned, it belongs to the group of double-stranded DNA viruses. The transmission could be with saliva, sharing drinks, really important, and sexually transmission. We have learned that herpes virus 2 is more the genital virus, and herpes virus 1 more the herpes on the lips. But nowadays we know that also additionally herpes virus 2, the genital herpes virus subtype, is also found in a lot of infections on the lips and vice versa. The symptoms, we have an incubation time of 2 days to 3 weeks. We can see watery blisters on the skin or mucous membranes of the mouth, lips, genitals, anus, flu-like symptoms. As an example, we have also in a lot of patients with this fever, muscle aches, swollen lymph nodes, problems when urinating, and also dangerous infection is the herpes keratitis, where you could come to blindness with pain, light sensitivity, and discharges. The main problem are the complications after that. We have a lot of evidence-based studies that the herpes simplex virus 1 and 2 both are neurovirulent, neuropathogens. So they can do multiple sclerosis. You can, as I mentioned, you can lose your vision. You could get an encephalitis. You could get latent infections, sleeping, snoring infections. You could get reactivations from your immune suppression. As an example, if you suffer from HIV or you get an organ transplantation, or simply normal stressing factors can do reactivation of this herpes simplex virus 1 and 2. Encephalitis, pneumonitis, and bone marrow suppression are also very famous doing a reactivation of this virus. The herpes virus 3, HHV virus 3, the varicella zoster virus. It's obligate intracellular. It's also double-stranded DNA virus. Transmission, airborne. It's really highly infectious, so it's transmitted in high concentrations through the air, so you can inhale over distances. It's easy transmission of this virus, high contagious, as I mentioned. And if you touch shingles, blisters also you can get an infection, or you can get a reinfection, as an example. Incubation time is around 10 to 21 days. You all know the chickenpox in younger people, but a lot of you know about herpes zoster in adults, the watery blisters on the skin, fever, tiredness, loss of appetite, and headache is described in this illness. Complications again. It's a neuropathogen, it's neurovirulent, so it encephalitis, it can also do pneumonia, bronchitis, and unfortunately in 10 to 20% this herpes zoster and reactivation from the nerve ganglia. Also famous the post-herpetic neuralgia, Mollaret's meningitis, the zoster multiplex on different parts of your body, on the skin, and the Ramsay-Hunt syndrome. That means painful blisters on tongue, ear, facial weakness, and hearing loss. And to me, let me say, most important information we got the last years, it's the inflammation of the arteries. In a study from 2017, I mentioned here herpes zoster, a reactivation of varicella zoster virus, of shingles, increases the risk of stroke and myocardial infarction. In 23,233 patients, they had a higher risk of apoplectic stroke in 35% and myocardial infarction 59% after herpes zoster. So that means if you suffer from herpes zoster, you have a tremendous risk for getting a stroke, 35%, or a heart attack. So because of the inflammation of the arteries. Epstein Barr virus, this is human herpes virus 4. Again, obligate intracellular double-stranded DNA viruses, very famous for mononucleosis or kissing disease. So transmission can be through saliva or through kisses. Drinking from the same glass, toothbrush, blood, sexual contacts, blood transfusions, organ transplantations. The symptoms are or can appear, incubation time is several weeks. You all heard about fatigue. It's a typical fatigue virus. All of these viruses doing mitochondriopathies, and all of these viruses are fatigue viruses, to mention that clearly, because they're using our ATP, our mitochondria, intracellular. So we learned that from SARS-CoV-2 models. The symptoms are also fever, flu-like symptoms, nausea, loss of appetite, lymphadenitis. So some of your patients, you will see and ask your patients for sometimes swollen lymph nodes in the neck as an example. It can do rash, sore throat, very important symptom for this, weakness, sore muscles. The complications, enlarged spleen, swollen liver, and association with non-Hodgkin lymphoma, BCLL especially. So don't be worried about that so much, but you need to check all patients with BCLL, with B-cell lymphoma or non-Hodgkin lymphoma for Epstein-Barr virus infections, 100% for sure. It's a very neurotropic virus. It is attracted to the central nerve system. Human herpes virus 5, it's the cytomegalovirus. Obligate intracellular double-stranded. It can be transmitted through blood fluids, urine, saliva, breast milk, sexual transmission, organ transplantation, blood transfusion. Very often we have forgotten about that virus, which is really so important beneath or very close to Epstein-Barr virus. The incubation is also several weeks. It's typical fatigue virus, fever, flu-like symptoms virus, lymphadenitis, swollen cervical lymph nodes, sore throat, splenomegaly. Also, congenital infection could happen with hearing loss, vision loss, seizures, mental disabilities, lack of coordination. Immune suppressed patients can get hepatitis, colitis. Also, this is a typical virus in your gut for leaky gut, colitis, Crohn's disease, very, very important virus we find in the world, retinitis, pneumonitis. So check all of your patients for cytomegalovirus, CV, so important. Esophagitis, polyradiculopathies, transverse myelitis, we come here to multiple sclerosis, subacute encephalitis, atrial hypertension, atherosclerosis, aortic aneurysms, association with non-Hodgkin lymphoma. So a really, really tragedy with this virus. Very, very neurotropic. It's attracted to the central nerve system. Human herpes virus type 6, the roseola, exanthema subitum, very important. Intracellular, again, a double-stranded DNA virus, one of the herpes viruses. Transmission, highly contagious, saliva, latency in salivary glands, hematopoietic, blood-building system. Symptoms, maybe you have seen some of the children with exanthema subitum. It comes and it goes. It's a sixth disease named. It's roseola with high temperature followed by a rash. Complications, that's always the chronic condition or reactivations. If you have a lot of immune stress, all of these viruses are stress triggered. Multiple sclerosis, neurovirulent, it's a cofactor in ME and or CFS, fibromyalgia, HIV infections, optic neuritis, cancer virus, temporal lobe epilepsy, Hashimoto. So you need to check all of your patients for HHV6 with Hashimoto's, liver dysfunction, liver failure, reactivation could also happen by organ transplantation. Human herpes virus 7. It belongs to the group of beta herpes viridae. It's obligate intracellular double-stranded DNA virus again. Transmission, birth canal, breast milk, saliva, allergenic blood products or transplants. The infections may be asymptomatic or associated with fever or febrile seizures. It can occur with or without rashes, exanthema subitum, vomiting, diarrhea, low lymphocyte counts. Complications, again, chronic. Neurological complications that occur alongside febrile diseases, infectious seizures, and temporary hemiplegia, febrile epilepticus, or clinical and laboratory signs of meningitis. Seizures occur more frequently in reactivated infections. Now, the last, I don't want to bore you, the human herpes virus 8, which can do also the Kaposi sarcoma, KSHV. In HIV patients or strongly immune suppressed patients, it belongs also to the herpes virus group, double-stranded, one of the herpes viruses. It's transmitted in the respiratory tract, in droplet infections and nasal secretions, shedding of viral particles into saliva, sexual transmission, intravenous drug use. The prevalence, as an example, in sub-Saharan Africa, up to 80%. Symptoms are fever, rashes, maculopapular, lymphadenopathies. All of these viruses are also lymphotropic, so they block your lymph flow and you need detox. As an example, we come later to that. These are lymphotropic viruses. Enlarged spleen, your spleen, your liver. Complications, a blood disorder known as pancytopenia, bone marrow failure, rapid progression to Kaposi sarcoma. Risk factors, immune suppression, cancer. Now I'm coming to the enteroviruses. These are, let's name them gut viruses. The entry is via aerosol or ingestion. So you could inhale it on a restroom. In a restroom, if somebody has it in the stool, it's high contagious. Then this, or you eat up some dirty meal, some dirty water, some dirty foods, and then it's coming into your body, and then you got sick. The replication is in the tonsils and in the Peyer's patches in the gut. And the virus is in the current acute fresh infection in the feces for sure. So you can infect others without maybe knowing of that virus. We have different subtypes of that virus group. Very famous is the poliomyelitis group, but we find more the Coxsackie viruses, which can infect the brain. It's also neurotropic, neuroviolent, encephalitis, paralysis. We have the echovirus, which is also doing neurological symptoms. We have the hepatitis A virus. You heard about that. It's a liver virus. It's a hepatitis liver infection. The echovirus and the Coxsackie virus can do the hand, foot, mouth disease or the herp angina. I come later to that. And the muscle infection, which can be a myocarditis, pericarditis, or also muscle weakness, myositis. So here's a list of the diseases caused by enteroviruses. So you can see that the poliovirus can do, as an example, asymptomatic infection. The Coxsackie also, they all can be asymptomatic, but they can persist in your body and they can be reactivated. And they all are neuroviolent. So they can persist in your body for years and can be reactivated. Silent carrier status, remember back, all of these viruses can do that. Coxsackie A and B, very famous, like the echovirus for doing myocarditis. So some of your patients will have heart rhythm problems, and the orchitis, also for the Coxsackie B1 and the echovirus. What about this echovirus or Coxsackie virus? My main interest is now the Coxsackie virus group A and group B. They are obligate intracellular. They belong to the enterovirus family. I have already mentioned that. It's a single-stranded RNA viruses divided into both groups A and B. High contagious, can easily spread from person to person. Fecal oral contamination, droplets from sneezes, coughs, so you cough each other like SARS-CoV-2, body fluids, utensils, toys, diaper changing tape. table, so also in planes. You can get infected everywhere, in families as an example. So it's also a family virus going around the families. The symptoms: gastrointestinal from entero, intestinal permeability is has got a problem. It's the leaky gut virus. It's the histamine intolerance viruses. It's the immune food intolerances viruses. We had a lot of food intolerances. The group A is doing the herb angina and can do conjunctivitis, hand, foot, mouth disease. Group B is more myocarditis, pericarditis, hepatitis, sclerodermia. Group A and B can do fever, rashes, sore throat, diarrhea, cough, fatigue, conjunctivitis, and loss of appetite, headache, night sweats, also very important, and aseptic meningitis. The complications, also very, very interesting. It's neuroviolent. They do a lot of symptoms. These Coxsackie virus can do like poliomyelitis symptoms. It's neurotropic. It can do also the, very important to me, the insulin-dependent diabetes mellitus. So it can do also autoimmune disorder. So check all of your children with juvenile diabetes type 1 for this Coxsackie virus. It starts with diarrhea, and in the end, you have the autoimmune disorder. You will develop diabetes in young adults. So that we discuss later on what we can do against this. Group A can do myositis. Group B also muscle injuries, degeneration of neuronal tissues, and so on. This is very, very important. Ask all of your patients for this so-called herb angina. This is small and symmetrical ulcers of herb angina, and it's sometimes your lifelong. It's misdiagnosed as streptococcus tonsillitis, which is wrong. So please ask and show. It's easy from Wikipedia to find a picture there. Show all of your patients these pictures. Ask them, did you have that from time to time? And a lot of them will say yes, 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 yes. And then you come very, very close to your diagnosis with Coxsackie. The echovirus, it's an enteric cytopathic human orphan virus. It's also picornaviridae and high contagious, again, the same, easily spread from person to person, fecal oral contamination, respiratory droplets, body fluids, and nosocomial routes. Gastrointestinal, again, it's leaky gut virus, histamine intolerances, food intolerances virus, multiple chemical sensitivity, insensitivity virus. It depends on the site of your infection. It can be involved in breathing difficulties, heart, mouth sore, sore throat, fever, chills, chest pain, severe headaches, photosensitivity, nausea and vomiting, eruptive skin rashes. It's commonly associated with ME and chronic fatigue and/or finding enteroviruses in 82% in stomach biopsy, so that all of these patients with ME have also an inflammation of the gut. It seems to correlate with a high percentage of these ME/CFS patients in a study. So you find a lot of paper literature about that. If you're interested, we have a lot of this. If the infection affects the membranes covering the brain and spinal cord, you could get meningitis, paralysis. The chest pain in the infection affects the heart muscle or sac-like covering around the heart, pericarditis-like feelings or inflammation, infection. And so also multiple sclerosis virus, acute transverse myelitis, and the mental status changing. So we have a lot of studies for that. Parvovirus B19. You can see on the right side, it's a DNA virus. It's common and highly contagious, spreads through respiratory secretions, saliva, sputum, nasal mucus. When an infected person coughs or sneezes, or high contagious like SARS-CoV-2, parvovirus B19 can also spread around through blood and blood products, sometimes called slap cheek disease. You see on the upper right side the picture of this child because of the distinctive face rash that develops, lethargy, loss of appetite, abdominal pain, bloating, fever or low body temperature, hypothermia, vomiting, severe, often bloody diarrhea virus. Complication, it can lead to serious health problems for the fetus. in pregnant women. Painful swollen joints looks like Lyme disease. Polyarthropathy syndrome, severe anemia could be misdiagnosed by BC as an example. Persistent vomiting, diarrhea can cause rapid dehydration, and in the end, it can also cause a septic shock. What are now the associations of all of these viruses with different health conditions? The ME International Consensus Primer recommends considering CMV, EBV, HHV6, and enteroviruses for sure. You need to think about that, and you need to check these viruses with some tests: EBV, CMV, HHV6, and enteroviruses. But to mention, this list is not completed. We find also chlamydia, pneumonia, mycoplasma, borrelia as an example, parvovirus, also other viruses, which I have named herpes simplex virus, type 1 varicella zoster virus. They all make ME. They all Fahrenheit sees enteroviruses as the key reason for ME, the key driver of ME. If you're interested, he did some books about that, and there are also some videos and some presentations available. He's a Canadian, fantastic Canadian scientist, and we understand 100% on the level we are discussing ME. Very interesting, cytomegalovirus. So we have paperwork about that, that high EBV IgG concentrations in the blood of patients with fibromyalgia, they are highly correlated with pain, intensity, and associated with fibromyalgia symptoms. So that fibromyalgia is connected to the immune response to certain infections, as it is with Epstein Barr virus and cytomegalovirus. Fibromyalgia also can be associated with varicella zoster virus. Here's the paperwork about that. So the herpes zoster is often followed up by chronic pain and fibromyalgia-like symptoms. Parvovirus B19 also can be associated with ME, CFS, as well as fibromyalgia. So just to show you some studies, if you could get this presentation, there's a highly, let me just mention, there's a highly association of parvovirus B19 and with fibromyalgia and also ME, CFS. Herpes viruses are often involved in neurological disease. So also herpes virus like EBV, CMV, HHV6 are highly associated with ME and chronic fatigue syndrome. In 2022, in a famous paper that was published about Epstein-Barr virus, may be the leading cause of multiple sclerosis. So it's now around 10 months ago. And in this paper, they said they have found really a very, very high correlation of this Epstein-Barr virus infections with multiple sclerosis patient. And they said also in this paper, this is a big step because it suggests that most multiple sclerosis cases could be prevented, also prevention by stopping active Epstein-Barr virus infection, and that targeting EBV could lead to the discovery of a cure for multiple sclerosis. And this is what we see daily nowadays. So also the post-COVID, we come later to that, is highly associated with Epstein-Barr virus and other viruses and other pathogens. In a next study, it came a little later. The study found that the risk of developing multiple sclerosis increased 32-fold following an Epstein-Barr virus infection. So it's pretty clear, it's pretty clear that Epstein-Barr virus is the reason for not all multiple sclerosis patients, but for most of them. So you need to check this patient, you need to treat Epstein-Barr virus. Maybe you have a chance to prevent or also to get to a healthy condition. But Also, herpes simplex virus, we talked about that, can do Alzheimer's disease. Very interesting. Chlamydia pneumonia, also aerogen bacteria, they both can do Alzheimer's disease. So if you have a patient with Alzheimer's, please check for herpes 1 and also for chlamydia pneumonia infection. So the viral involvement in autoimmunity is well documented. Viruses, they do molecular mimicry, bystander activation, we name it, or viral persistencies. That could be a possibly perfect storm of all three. I will show you examples: SLE, lupus, type 1 diabetes, ulcerative colitis, sarcoidosis, myasthenia gravis, and Graves' disease. In autoimmune neuropsychiatric symptoms like PANS and PANDAS, 2, we find also lots of patients with influenza A, varicella zoster virus, Coxsackie virus, Bartonella, Babesia, Lyme disease, Mycoplasma, and for sure what we all know to check for Streptococci. Patients often have more than one infection. All of these patients have chronic multiple infections. If you find one infection, I can promise you, you find for sure different other ones. So what cancers are viruses associated with? I will show you that the B-cell non-Hodgkin lymphoma can be associated with Epstein Barr virus and cytomegalovirus in these papers. I also that how Epstein Barr virus causes blood cancer. That was a study done at the University of Sussex in November 2016. Professor said, this is a key step towards uncovering how this common Epstein Barr virus, which affects thousands of people every year, causes blood cancer. So what was the developing of all of that? We developed panels, test panels, where we have a lot of evidence-based paperwork behind that. Which pathogen, which bacteria, and which virus can do which type of cancer: lymphoma, monoclonal gammopathies, glioblastoma, prostate cancer, lung cancer, angiogenetic tumors, esophageal cancer, breast cancer, cervical cancers. So you can get this overview if you want. SARS-CoV-2, COVID-19, and viral reactivation. This paper came also, let me say, over a year ago in 2021. And they said the Epstein Barr virus, the first time it was published, Epstein Barr virus activation resulting from the inflammatory response to coronavirus infection may be the cause of previously unexplained long COVID. So they found in 66.7% of long COVID patients, they found Epstein Barr virus reactivation, and they did the early antigen. You can see on the right side at the bottom, EBV early antigen. So, or the IgM viral capsid, the EBV VCM, you need an IgM antibody. So ask a laboratory, please, I need the Epstein Barr virus early antigen and the IgM antibody to diagnose the activation long COVID or post-COVID patients. But it can also work the other way around. Epstein Barr virus increases susceptibility to infection by SARS-CoV-2. There's also paperwork about that. Now everybody says, yes, everybody had or has Epstein Barr virus. This is 90% had this, but not all have active infections for sure. But we have a lot of silent carriers, a lot of patients, they carry without getting symptomatic. But if the immune system is weakened, as it is with SARS-CoV-2 all the way around, then it's the whole cocktail is coming, explosion of the whole cocktail of this, and it's a reactivation. We name it an opportunistic infection. So we have also evidence that an active virus infection in the background increases the susceptibility to infection by SARS-CoV-2. So COVID-19 can also cause reactivations of varicella zoster virus. This came up in April 2021. So we know now that also varicella zoster virus can be reactivated and can be the reason of post-COVID symptoms. cytomegalovirus, the same. Cytomegalovirus, CMV, reactivation can also induce immune dysfunction, and it can be a driver of pathogenesis in patients with severe COVID-19. So it makes sense to diagnose patients with COVID-19 and especially the reactivation if you have a post-COVID syndrome. Virus, one, exactly the same. You need to check all of your patients with post-COVID, long COVID for a simplex virus reactivation. And I show you here an example what we see daily. That was a patient with cytomegalovirus infection before COVID diagnosis. In November 2021, the cytomegalovirus lytic antigen was positive, 21. So the infection was already active, but you can see in April 2022, after COVID, was a massive explosion of this virus load, of this activity. So the patient was getting so sick by this reactivation of cytomegalovirus. So it was also in the body before, but then COVID came, and then was the whole bunch coming out, infection, inflammation, immune dysfunction. So the immune system was suppressed. Patient got very, very sick. But what does that mean? You have an option to bring back the cytomegalovirus lytic antigen away into the latent phase. The latent phase is possible, but not the lytic phase. This is not allowed. This means reactivation, active virus replication, a massive reactivation of cytomegalovirus. We see that daily. As well as Coxsackie and echovirus. In this, you can see a different patient with double infection, Coxsackie virus, IgA, highly active titer 320, echovirus, 2 enteroviruses, highly active, reactivated from SARS-CoV-2 infections. Testing techniques. Testing can be either done via antibodies, EliSpots, or PCR. Antibody testings, we name it the B cellular immune responses. We can check for IgG antibodies, IgM, and wherever it is possible, do an IgA antibodies. I can pray about that. Immunoglobulin A is the key to diagnose reactivations. But what we also really need is the T cellular test, the T cellular immune responses, immunity responses, a technique for testing the other arm, the cellular T cell immunity. It is called the EliSpot technique, a fantastic technique, certified technique, IVD registered, accredited technique, one of the best we have in the world, 20 to 200-fold more sensitive than antibody tests, with one exception, the IgA test. This is really also very, very good test. IgA, so I'm absolute laboratory fan for IgA and the EliSpot T cell immunity. PCR is difficult. You need a biopsy in blood. It's really complicated. Maybe a lymph node biopsy. Highly sensitive antibody tests are available nowadays for all viruses. I show you here the reactivation of varicella zoster virus with the IgA antibodies. The IgM doesn't bring you forward. IgM is the fresh infection, but we are checking for reactivations, IgA. So really important. And for Epstein Barr virus, the early antigen, as you can see here. This is a positive early antigen with the IgM. This is clearly, my opinion, a reactivation of Epstein Barr virus infection. But who knows? I don't have the clinical aspects behind that. This is a job of the diagnosing clinician. If you don't EliSpot techniques, the EliSpot techniques, we have a lot of teaching books about that, a handbook of the EliSpot technique. It's really invaluable technique in immunology. We need this in the von gamma release assays. So there's no way around to ignore this test nowadays. And this is the EliSpot result. For most viruses, we find so high active lytic replications with patients with multiple sclerosis, patients with post-COVID syndrome, with patients with cancer. So active infections. you cannot imagine that. The latent phase means bring it back into latency. So this is a monitoring marker. Also in the first diagnosis, you need the EliSpot, the lytic antigen, otherwise you got lost and you will not diagnose. Herpes viruses, Epstein Barr virus, cytomegalovirus, also showing you a double infection with that, with cytomegalovirus. This is an example that Epstein Barr virus and especially cytomegalovirus can do anti-nuclear antibodies, also lupus as an autoimmune disorder. So this is the T-cell testing EliSpot. We have a massive, fantastic development now with this virus. We can also do it for Yersinia. We can do it for HHV 6, 7, 8, SARS-CoV-2, fantastic test. We can do it for yeast and mold, Candida, Aspergillus niger. So we find so many and so many infections, double, threefold. So it's horrible. Every patient has chronic multiple infections. We see in the chronic conditions, not the fresh conditions. So checklists and other resources. Years ago, let me say, I came from Lyme disease, who knows me, 20, 25 years ago. We developed a checklist for Lyme disease, accordingly to Boroscano's checklist, but I think we did a more comprehensive one that time. We have also a co-infection checklist, and this is really important. It costs nothing. Your patient can fill that out. So it can be downloaded. It's digitalized system, automized ranking. So the more symptoms you have for an infection, the more obvious it is that your patient is suffering from it. Okay, so in this case, you have 8 symptoms for Coxsackie and echovirus. You have 8 symptoms for herpes virus group, and as an example, 7 symptoms for Bartonella infection. We developed over the last 1.5 years also post-COVID checklist, so we can differentiate by that for chlamydia, mycoplasma, Yersinia, Campylobacter, H. pylori, herpes simplex virus, Epstein Barr virus, EBV, CMV, varicella zoster, HHV6 clinically. It's done from the symptoms. This doesn't mean that it's now proven, but you have a clinical suspicion. We are all clinicians. I'm also a medical doctor. So we need to know which patient has which symptoms. And then we do ranking of the symptoms and by the numbers of the symptoms. And then we do the corresponding test to spare money simply. And this is how it works now, electronically filled out. And Armin is very active, easily in doing some panels for you. If you say, okay, I have a cardiac problem, I collect a lot of paperwork, which virus, which bacteria can do cardiac problems and skin rashes or rheumatoid arthritis, very famous panel on the on the right side. So Campylobacter, don't forget about the gut bacteria, the enterobacteria, also important, chlamydia, mycoplasma. So we find nearly all of these patients chronic multiple infections. Therapies. So what is now going on with therapies? I'm now more fascinated about herbs and other complementary therapies for viral infections, because traditional school medicine does not offer so pretty much information. We have some virostatics like ganciclovir, acyclovir, or valacyclovir, but they are virostatic. So I'm, let me say, more favorizing now the herbs. And we have as example, licorice or anthocraphis or skullcap or dandelion, also Artemisia annua. I know that a lot of therapists are using Artemisia annua. This could also being used or tried out in herpes viruses like Epstein Barr virus and the virus 1. We have also black seed oil, quercetin, zinc, curcumin, very famous, cistus, Canus T as an example, or other products. The aminocyst L-lysine. So every time I say, oh, you need L-lysine for virus infection. So I think this is now a standard among virus therapists. L-lysine, very, very important. L-lysine, curcumin. It's clear these are not specific therapies for one virus, so but they can be used for a lot of viruses, and try that out and you will succeed in some patients or many patients. I cannot give you statistics, but it's a great option for patients. Glutathione is support for immunity, natural killer cell activity. The NAC, the precursor to GSH, mucolytic or SARS-CoV-2 spike protein conformation. So we have a lot of immune supporting options, as well as medicinal mushrooms to help the switch Th1, Th2. So what we find in chronic infection, it's a switch to Th2 and less Th1. So we need to work on that. As an example, it's just examples, reishi, agaricus platzi, so just some examples. Also, multiple flavonoids can be used with antiviral activities. So this is a list about that. We cannot go into detail with all of that. This is just an overview for you. But we have options which don't belong to the traditional school medicine with virostatics. So, but we have Chinese medicine and also other options where we can use. I highly recommend a book from Stephen Harapuna, The Herbal Antivirals. I think this is a must-have for therapists caring about that. Herbal Antivirals from Stephen Puna. Also, there are some structured strategies from Dr. Semyanek and Dr. Fitzgerald. So also some options in how to approach COVID-19, to mention that. Also natural antivirals, there are some GP information leaflets about that. We have tailored testing protocols for microbe disease correlations. I mentioned already, this is also a new product. I don't want to do marketing about that, so I don't have any conflicts of interest as an example for these products. To me, it's now the whole model. Yeah, maybe we go back. I don't know if it's there, but what's for me fantastic herbs are Tacuna and Hotunia. These are from this Cowden protocol. These are really great herbs. We have helped so many patients with herbal therapies also. These are all options. We don't have a wonder pill. We don't have a wonder therapy. We don't have a wonder method, but we have options for these patients. Don't give up. Give them some chances. Give them some options. But what is pretty clear nowadays that we have intracellular always infections, viruses and bacteria. We have genetics, epigenetics in the complexity of the predisposition. We have the personal history with allergies, intolerances, accidents, the dental status, the past or present comorbidities, differentials. We have the environment around us, occupational hazards, pesticides, geostress, electromagnetic fields, environmental toxins, heavy metals. So one discipline is not excluding the other. We need a cooperation model to cooperate with all of these disciplines. But on the other side, I swear you will find in nearly all of these patients intracellular active infections. Now I'm coming a little to the end. I want to show you in an appendix. I mentioned the EliSpot techniques, and we'll show you some more information about enteroviruses. This is how the method in laboratory works with the EliSpot techniques. We isolate lymphocytes. We bring them on a well. The well is coated with monoclonal cytokine-specific antibodies. We are using interferon gamma and interleukin-2 for the iceberg as an example. We incubate the blood from this patient with cells and antigens. Specific cells release the cytokines or not. We have positive, negative controls. So the test is really, really, really good. It's one of the world-leading tests now, done in a lot of laboratories in Germany as an example. In the next step, we add secondary antibody complexes, and then is a color reaction on it. And the end, we have on the left side at the bottom, you see all of these spots. This is the final result of EliSpot. One patient So you see a lot of spots there that were all lymphocytes we isolated from this blood of this patient, documenting interferon gamma release in this patient. So really, really helpful test. If you don't believe in this method or you hear other opinions from other laboratories or doctors, there's a lot of references behind that. It's not my test, so you will see that a lot of reference, because I want to work evidence-based. My laboratory is accredited, so we don't want to do in-house tests or home brew tests, or we want to do high-quality tests. What about the enteroviruses? Dr. Barnheit did a good story. If you're interested, there are two links: Emmy Brown's ME enterovirus story, and he found in a lot of papers that the enteroviruses, Coxsackie and echovirus, especially in Canada, we find a lot of Coxsackie viruses. In England, many Coxsackie viruses. It's horrible. And double infection with echoviruses. You can go onto Byron Height's website and also some links, really helpful. This is a tailored testing protocol for multiple sclerosis. We check for Borrelia for sure, for Lyme disease. Tickplex basic is a test for persister forms, intracellular forms of Borrelia. CD57, CD3 cells. This is very important for the cellular immune level or deficiency of natural killer cells, and the T cells and the B cells. Also, chlamydia pneumonia plays an important role. We do the IgA antibodies, the EliSpot, and also do both IgA antibodies and EliSpot belong together. Th1, Th2 tests, don't miss one information from your laboratory. Bartonella EliSpot, IgG-IgM antibodies, Coxsackie virus. I can pray that virus, do that. You will find so many Epstein Barr virus infection, or many. Cytomegalovirus, don't forget that, many. HHV6. And don't forget, all of these patients have chronic multiple infections. That's not one patient with just one infection. We find 3, 4, 5, 6, 7, 8, 9, 10 or more infections. This is an Alzheimer's or dementia panel. Also Borrelia, Lyme disease plays a role, chlamydia, pneumonia, the mycoplasma pneumonia, Coxsackie echovirus, herpes simplex virus, very important, Epstein-Barr virus, and cytomegalovirus. For Parkinsonism, we have also developed test panels, Borrelia EliSpot, Tickplex, CD57 cells again, chlamydia, mycoplasma, Bartonella, Coxsackie virus, EBV. You hear always the same, but believe me, we have a lot of always the same infections in the patients. I do hundreds of tests every day, and I'm shocked myself how many of these patients with post-COVID, as an example, or patients with multiple sclerosis or chronic fatigue or ME, Parkinsonism, all show these viruses and all of these bacteria. And it's so important to know what to treat. You cannot treat blind a patient. You need to know which pathogen is active in which patient. We are profilers. We do individual profiles for individual patients. So not every patient has every infections for sure, but every patient has lots of infections, but we don't know which infections before. We cannot foresee that. So we need some tests, and then we know, and then we can treat, and then we can stage, we can monitor this patient. Where do viruses come from? There's also a lot of articles about that. And in the end, I want to say thank you very much for your attention. Maybe a last word to that before I close my presentation. Nowadays, it's pretty clear that we need to diagnose and treat 3 I's. The first I, we need to diagnose and treat the infection. We need to diagnose the second I, which is the inflammation. We need to and treat the third I, which is the immune dysfunction. So it's not enough if you just diagnose and treat one of this. You need to know what is the inflammation in this patient? What is the cytokine, maybe as an example? What is the cytokine storm, Th1, Th2 dysfunction? You need to know what is my immune dysfunction. You need to know what about my natural killer cells, what CD56, CD57, what about CD3 cells, what about my immune globulins as an example. So you need to know, and then you can treat specifically. And in the final end, I want to say you need also to diagnose the right infection in your individual patients. And then thank you very much.
Okay. So that brings us to the end of the presentation for today. I just want to remind everybody that listens to this presentation, it can be viewed in the NANP members area, along with a vast selection of cutting-edge webinars. As mentioned, each webinar includes a corresponding quiz, which is worth 1 continuing education credit. So if you have an interesting topic that you would like to present, or you know any speakers that you would like us to host, if so, please reach out to me by emailing me, andrea@thenamp.org. This brings us to the end of our discussion. Thank you for listening.